Exactly 7:59.
Yeah.
I'll wait till 8.
Okay.
All right, so then whenever I turn this on, we're good. Okay.
Yes.
All right.
All right, it's exactly 8 o'clock. So we can get going because there's cool people already here. So good morning, everyone. Welcome to Grand Rounds. For anyone who doesn't know me, I'm Alexis Eastman in the Division of Geriatrics. And happy spring, right? It's very exciting. Hopefully it won't snow again, right? The weekly snowstorm maybe is over for the year. That would be nice. So without further ado, it is a distinct pleasure to introduce Dr. Melissa Dattalo as this week's Grand Rounds presenter, someone who I've worked with and known for many years at this point. Gosh. Dr. Dattalo completed her Master's of Public Health, medical school residency and chief year at Johns Hopkins, and subsequently we were fellows together in geriatrics here at UW. She went on to complete an advanced fellowship at the VA. Successfully and amazingly, and has been faculty, I think, since 2016, if I remember correctly. Since that time, she's had a skyrocketing career and become a national leader in home-based care. She successfully launched the UW's home-based primary care program, which is an amazing thing if you have not seen it. It doesn't merely rejuvenate the house call, it really truly brings all the benefits of an outpatient primary care clinic to a patient's home. And not only did she do that, she shepherded it through a pandemic and even expanded it during that time, which is a huge feat. She took her program and it joined the National Home-Based Medical Care Quality Improvement Learning Collaborative, which I had to write down, which is a Hartford grant-based network based around expanding and developing home-based care across the country. She presents nationally on this topic regularly and has mentored multiple rounds of residents, fellows, medical students through the principles of home-based care. She is now also the medical director of all home-centered care at UW. And in that role, she is diligently and tirelessly working to develop new, exciting, and innovative home-based care programs, including home-based hospital care, which is going to launch later this year and is incredibly exciting. It's going to revolutionize the way we take care of patients who need hospital-level care and give it to them in their homes. How wild is that? Conveniently, also the topic of today's Grand Rounds. So without further ado, please join me in welcoming Dr. Dattalo and her presentation, Hospital at Home, From Research to Practice. Thank you.
Thanks so much, Alexis, for that very kind introduction. And today I'm very excited and it's an honor to talk with you all about Hospital at Home. And this is a model of care that's becoming increasingly available throughout the US. And as Dr. Eastman said, it will be available for our patients here at UW starting in July of 2023. So I'm really excited to review the evidence behind the model with you all today, especially because many of you in the audience have been involved in planning and leading implementation efforts. And for those who haven't been, it's important to understand enough about the model to know how it can best serve your patients once it becomes available. So I have no financial disclosures. And by the end of this talk, I hope you'll be able to identify the patient populations most likely to benefit from Hospital at Home, compare outcomes of Hospital at Home to traditional hospital care, apply an implementation science framework to predict barriers and facilitators to spread of this model, and to identify equity considerations related to implementation of Hospital at Home. So before I get into the research and the literature review behind this care model, I wanted to share a personal story and my motivation to work in home-based care. This is a picture of me as a teenager. I'm with my grandparents. I grew up living with my grandparents as they got older and their health declined. My mom became their primary caregiver. And they experienced a lot of the hazards in our healthcare system that you might expect older adults to encounter, from delirium-inducing medications to a failed transition of care for my grandmother, where her advanced directives were not communicated to a nursing home, and she actually ended up being resuscitated against her wishes. My grandma and grandpa had very different trajectories at the end of their life, and a bright spot in their care was actually my grandpa getting connected with a house call physician. And I remember how quickly he was able to understand my grandpa as a person, what was most important to him and our family. And this house call physician was really the first person to acknowledge the caregiver burden that my mom was experiencing. So all of this led to a much more personalized care plan. My grandpa and my family were able to make the decision for him to enroll in hospice, and he died very peacefully in a familiar environment surrounded by family. So here I am now, over 20 years later, a lifelong learner of how home-based models of care can best serve patients and families. And today we'll focus specifically on hospital at home and talk about this in both research and what it means to translate that research into practice. So first we'll review some of the evidence behind who can benefit the most from this care model, what's the impact on health outcomes, and then considerations when translating this research into practice, specifically barriers and facilitators to dissemination, and important equity considerations when trying to implement this in practice. So we'll start with who's most likely to benefit. And I was hoping to make this a little more interactive for our remote participants at home on Zoom. So there are audience response questions, and if you're participating remotely in Zoom, feel free to answer the poll. If you're here in person in the audience, try to commit to an answer in your mind or write it down. If you do log into the Zoom, there's a risk of having an echo if your speakers are on. So if you do that, just make sure your speakers are off. So the first question is about Peggy. She is a 78-year-old woman. She has heart failure, COPD, and a pacemaker. She's been diagnosed with aspiration pneumonia and a COPD flare in the emergency room. She has a new 2-liter oxygen requirement. That's not something that she uses at home. And orders are placed for hospital admission. So the first question is true or false? It's possible for Peggy to safely and effectively be treated for her condition at home with support from a home-based hospital team. So think of an answer, and then Julie's helping us track the poll responses remotely. Okay, so 82% of the audience who answered the poll said true. And the correct answer to this question, is true. And we know that because it's actually based on a real story. So Peggy was a real patient. Her story is available on the Johns Hopkins Hospital at Home website. And she received hospital level care at home through one of the original hospital at home programs in New Mexico that was part of a demonstration project back in 2001. So this is a picture of Peggy. She has her nebulizer machine there, her oxygen equipment, her physician is there who's been doing daily visits. And if you look closely, you can see her cat in the lower right-hand corner. This program's still up and running today. It's been growing over the past 20 years. And this is a quote from one of the nurses who works in the program. She says, "People are so much happier at home and they do beautifully, and they tend to get better faster and not go back into the hospital. They've got their family, their animals, and everything they want around them." So what do we mean when we say hospital at home? This is a very complex intervention. You can imagine it's like building a hospital without walls. And we can divide that complexity up into 6 core components. So it starts in the emergency room or the brick and mortar hospital where patients are identified to need inpatient level care that can safely be delivered at home. Once they're home, they will get at least daily physician visits, and this can be in person or through telemedicine. They would also get at least twice daily nursing visits, and the in-home care team can be much broader than that. It can include rehab members, physical therapy, occupational therapy, social work, community paramedicine, but they will need at least twice daily nursing visits. Any durable medical equipment that the patients need would be provided to them. So in Peggy's situation, that would be oxygen, nebulizer equipment. It could include things like a bedside commode or even a hospital bed. The patients at home need access to the full range of pharmacy services, including in-home infusion. So if they need IV antibiotics, IV diuretics, IV fluid, all of that can be provided to them. And finally, there's a full range of ancillary services that are necessary in the home, especially diagnostic services. So any labs, x-rays, EKGs, ultrasound, even echocardiogram can be done in the home if needed for the patient's care. So who can benefit the most from hospital at home has evolved a lot over time. And what I am displaying here is that there's been 3 landmark trials of hospital at home in the US. And almost everything we know about hospital at home in the US, all of the papers published can be traced back to one of these 3 studies. It was originally adapted to the US from international models back in 2001 from Dr. Bruce Leff, who's a geriatric health services researcher. And at that time, it really was focused on a target population of older adults because they're more vulnerable to hospital complications. And at the time, it was only focused on 4 target illnesses. So heart failure, COPD, pneumonia, and cellulitis. Over time, that has expanded greatly to be able to serve even more of a broad target population. So from 2014 to 2017, there was a CMMI Medicare demonstration project at Mount Sinai where they were able to expand the services to all adults ages 18 plus and also expand the target conditions to treat 19 target illnesses. The first randomized controlled trial of hospital at home in the US wasn't done until recently. So just in 2020, that occurred at Brigham and Women's Hospital. And again, serving a broader range of medical conditions and adults of all ages. So what is it gonna look like when hospital at home is available here at UW? Wanted to share some of the eligibility criteria really adapted primarily from the RCT at Brigham and Women's Hospital. So starting in July, patients here at UW who are age 18 and plus and would otherwise be admitted to the general medicine service for 19 conditions could receive care at hospital at home. They would be able to get all of those diagnostic services I mentioned earlier at home, but wouldn't be expected to need telemetry, blood products, advanced imaging like CT or MRI or inpatient procedures. All of those things could be done in the emergency room before the patient's transferred home. There's some criteria for vital sign stability, and they wouldn't, at the time of the program launch, be able to receive IV controlled substances at home. And they would have access to only limited consulting services. But this is something I think that's really special about our version of hospital at home here at UW. And really kind of on the cutting edge of hospital at home programs is that we're really grateful for great support, not only from our hospital medicine colleagues, but also many of our subspecialty colleagues. So at the time of the program launch, our patients will be able to have telemedicine consults from our Geriatrics ACE consult service, dermatology, infectious disease, and addiction services. So in addition to medical criteria, there's also important safety criteria for the home environment and social support. The home environment needs to be close enough to the hospital so that if care needs to be escalated, it can be in a timely fashion. The home needs to be accessible for some of that in-home equipment. The living environment needs to have electricity, running water, and finally, there are some important social support criteria to consider. There is not going to be a nurse or a CNA available 24/7. And so patients either need to be able to meet their personal care needs at home or have someone who can assist in meeting those needs. There is a telemedicine component to hospital at home, both to have on-demand access to our care team and to participate in some of those telemedicine consults. So we'll be providing patients with a tablet and they need to be able to use it to engage in the visits either on their own or with assistance. They would not need to have their own internet, and we can talk more about this when we get to equity considerations as well. So that was an overview of the target population best matched with this intervention. And so now we'll review some of the evidence behind the impact on health outcomes. Health outcomes is a really broad category, but for the purpose of this literature review, we'll define the health outcomes as the 5 components of the quintuple aim. And that's improved population health outcomes at lower costs with better patient experience, better clinician experience, and finally, being able to accomplish all of this in an equitable way that improves health disparities. So that brings us to our second audience response question. Again, if you're participating remotely on Zoom, please answer the poll. If you're here in the class, in the auditorium, write down your answer on a piece of paper or commit to an answer in your mind. So this question is, compared to traditional hospitalizations for similar levels of illness, research studies have shown that hospital at home can have all of the following outcomes except. So which one of these does the research not support? Lower rates of delirium, lower costs of care, lower readmission rates, or improvements in caregiver burden? We still have some responses coming in. Okay, so we've got answers across the board here. So several people said the evidence doesn't support lower rates of delirium, some lower costs of care, lower readmissions rate, but the majority picked improvement in caregiver burden. And that is the correct answer. So there's no evidence that hospital at home improves caregiver burden. And actually, in contrast, there's some concerns that it might add additional stress or additional tasks to caregivers if there's personal care tasks that hospital staff might otherwise do that may be shifted to family members. There is great evidence for some of the other outcomes, and we'll review that, starting with clinical outcomes. So what I have here is a table from the original national demonstration project that happened in 2001. This was at five sites. 3 of them were Medicare managed care sites, 2 of them were VA sites. And this was an observational study. So they had an intervention group who received hospital care at home for those 4 conditions I mentioned before, and equivalent observation group who received care in a hospital building. Again, this was at a time when the target population was older adults, so they were at higher risk for some of those hospital-acquired infections, delirium, or other complications. But the study did show that there were significant reductions in many of those complications among the intervention group. That includes delirium, use of sedative medications, and emergency situations. What about patient experience? So this data is from the Mount Sinai Medicare demonstration project that happened from 2014 to 2017. And again, this was an observational study. It was a case control study, and they surveyed all of the participants with the HCAP survey, which is a national survey that goes out to all patients who are hospitalized nationally. And the intervention group receiving hospital care at home was 3 times as likely to have the highest overall hospital rating on their HCAP survey compared to the control group. There were some mixed results when you break it down into different categories, and I just wanted to highlight a few of them here. So areas where there was a relative advantage for the patients receiving care in hospital at home was with communication with nurses, physicians, communication about medicines. Areas where there was a relative advantage of the brick and mortar hospital was satisfaction with pain management, and then there was no significant differences in satisfaction with discharge information. So patients had higher levels of satisfaction. What about their family members? So remember, we said earlier there may be some concerns about possibly increasing stress on family members. This is not a survey directly of caregiver burden or caregiver stress, but it was a survey about satisfaction with care specifically that went out to family members of patients who were receiving hospital at home. Not all of the family members were caregivers. So 59% of family members in the hospital at home group provided some type of personal care to the patients receiving hospital at home. 44% of family members in the traditional hospital group provided some type of care. So even though not everyone was a caregiver and there was a little bit higher prevalence of caregivers in the hospital at home group, the satisfaction with the care provided was much higher in the hospital at home group. And again, that includes physician, nurse, and staff satisfaction, comfort, and convenience. There was no difference in satisfaction for safety and the admission process, but there was higher satisfaction rates with the discharge process when patients received their hospital care at home. So we did see some evidence for improvements in clinical outcomes, some evidence for a relative advantage when it comes to patient and family satisfaction. What about cost? Is hospital at home cost effective? So those 3 landmark studies that were done in the US all showed a very promising impact on cost, primarily through mechanisms of reduced length of stay and lower readmissions. And this is a table from the Mount Sinai Medicare Demonstration Project that showed the length of stay and for hospital at home patients compared to traditional hospital patients was lower by over 2 days, and the readmissions rate was cut almost in half. One of the limitations of these studies is that they were both observational studies, the original one back in 2001 and the Mount Sinai Demonstration Project in 2014. So there's certainly a risk for selection bias. So what did the randomized controlled trial show? This was the first randomized controlled trial that occurred of hospital at home in the US at Brigham and Women's Hospital in 2020. And they did a fairly extensive cost effectiveness analysis. And what they found is that the mean cost of that acute care episode at home was 38% lower for patients who receive care at home compared to patients who receive care in a traditional hospital. And there are some criticisms or limitations of the methodology that they used. Specifically, when they were doing that calculation, they were only considering direct costs and weren't including physician labor. So I also wanted to include some of the sensitivity analyses they did just to show how that changes the cost savings. And physician labor is very expensive. And per patient, it may even be more expensive in the home because each physician can care for fewer patients at a time than they do in a hospital building. But even when they accounted for physician labor, they still were able to find a 19% relative cost reduction. And on top of that, if they actually accounted for the financial cost savings of those reductions in hospital readmissions, it increased the cost effectiveness even more. So counting physician labor, counting the reductions in 30-day hospital readmissions, they showed a 25% relative cost reduction. So finally, what about the equity arm of the quintuple aim? And with any intervention, it's important to know whether individuals representing the full range of socioeconomic statuses, race, ethnicities can all both access the care model and also once they access it, receive a similar benefit. And we didn't have much information on equity outcomes until just recently. This graph is from a paper that was published last year in 2022. This was a subgroup analysis of the Mount Sinai Demonstration Project. And they divided all the participants into 2 groups, a low SES group and a high SES group. And the way that they defined low SES was patients who had Medicaid insurance or who lived in neighborhoods where over 20% of residents were living below the poverty line. And so one promising result here is that individuals in the low SES group and high SES group were equally represented in both the intervention group who received hospital care at home and in the control group in the hospital. So there didn't appear to be any systematic exclusion of patients with low SES, and they had equivalent access to the intervention. The second important finding is that there were no differences in outcomes. So both experienced similar reductions in hospital readmissions, similar reductions in ED revisits. And if you look at this graph, the confidence intervals are very big, much bigger than the original study, because making these subgroups, they essentially cut the sample size in half. But it is reassuring that the point estimates are similar, as you can see here in the graph. And the authors actually hypothesized that the reason the confidence intervals are so much tighter around the low SES group is because it's possible that individuals who are facing challenges addressing social determinants of health could be better served through hospital at home, because it's an opportunity to be able to be in someone's home, understand their lived experience, be able to see any unmet social support needs. And if your intervention is designed thoughtfully, connect them with resources and be able to address them. So if there's evidence that the hospital at home model can be safe, effective, and equitable, why isn't it more widely available? So this is where we're going to talk about that translation step. How is this implemented in practice, and what are some barriers and facilitators to dissemination? Excuse me. So this brings us to our third question. Which of the following intervention characteristics of the hospital at home model poses the largest barrier to dissemination currently in the US? So there's 4 potential barriers to spread here. As of today, which one of these is the largest barrier to spread of this intervention? A, not enough evidence of safety. B, lack of adaptability of the model to different health system contexts. C, no payment models to support the cost. Or D, complexity of the intervention that limits the ability of organizations to try it on a small scale. I'll give you a minute to answer. Do we still have some answers coming in? Okay, so we've got a pretty big spread of answers here. It looks like the most popular answer was no payment models to support the cost at 44% of the audience. 40% of the audience said complexity of the intervention. So 4 years ago, C would have been right. So there previously were not payment models to support this unless you were part of a VA system or other integrated health system. But that's actually no longer the case. There's a reimbursement mechanism from Medicare that we'll talk about in a minute. The correct answer to this question is D, the complexity of the intervention that limits the ability of organizations to try it on a small scale. And in order to fully explain the answer to that question, I'd like to give you just a very brief overview of something called the CFIR model. This stands for the Consolidated Framework for Implementation Research. And this is basically an umbrella model that combines over 50 different implementation science models meant to explain the process of translating research into practice. So you start with an intervention, which is circled in yellow here. And maybe the intervention's been tested under research conditions. It's never been implemented in the real world, but it has some core components that define it. There's core components that make up hospital at home, and those core components are required to produce the evidence-based outcomes. But when translating that intervention into practice, there's parts of it that will need to change. They'll need to be adapted. The exact same hospital at home service that works for Peggy in New Mexico isn't going to work in Madison, and it needs to be compatible with the needs of patients, with the needs of local stakeholders and the local health system context. So this adaptation process circled in blue is an iterative process that's ongoing, and will keep going until it achieves a good fit with the settings and the people involved. So in the end, you get what's circled in green, and that's an adapted intervention that still contains the core components of the model that make it effective, but is also adapted to be compatible with the real world practice setting. So we talked about the core components of hospital at home. They are complex, and it takes a lot to get all of these components in place. And you can imagine there might be situations where, you know, an organization could be tempted to take shortcuts or missing some of these core components. And any of that would have the potential to jeopardize outcomes or even patient safety. So it's a really important step in the spread of this model that Medicare has actually translated these core components into regulatory requirements. And as of November 2020, Medicare is offering a waiver program. It's called the Acute Hospital Care at Home Waiver. And this allows health systems to be reimbursed for delivering hospital level care at home at the same rates that they would be reimbursed for care in a hospital building. And this originally started as part of the COVID-19 emergency response, and it was meant as a way to help offload hospital capacity. Organizations can apply to be a part of this waiver. The application process is a lot like applying for a grant. You put all of these, you tell Medicare how you're going to put all of these components in place. There's an interview process. And then if your application is approved, you can start taking care of patients. And then there's ongoing oversight after that, including sending quality metrics to Medicare on a weekly basis. As I said, this was originally part of the COVID-19 emergency response. It's been a very successful and popular program, so it's no longer tied to the emergency response. So even after that expires, this waiver program has been extended at least through December of 2024. And there's been a lot of uptake of the waiver across the country. So as of this month, as of March of 2023, there are 277 hospitals in 37 states that Medicare has approved to deliver acute hospital care at home. Our waiver here at UW Health was approved in September of 2020. And we haven't cared for any patients yet, but starting in July, we will, and be joining our other colleagues in Wisconsin in being able to deliver this care to our patients as well. So those core components in yellow are really the foundation, the things that are needed to make reproduce the evidence-based outcomes, but there's also adaptable components in blue. And these can vary widely in different practice settings and also change over time at the same site. So, you know, as complex as the intervention is, you may be surprised to hear that it's a very adaptable model, but there's actually a lot of adaptable components to it. And these can vary very widely across settings. So if you've seen one hospital at home program, you're probably not going to see another one exactly like it. And one of the biggest areas of differentiation is whether you're doing a substitutive model, which is mainly what we've been talking about so far, where the patient's entire hospital stay is substituted for hospital at home, versus a transfer model where patients may be admitted to a hospital building, maybe spend a night there or two, continue to need inpatient services, but then be transferred home to continue to receive them. There's also variation in how long patients are followed. In addition to that, 3 to 5 day length of stay, there's some programs that incorporate 30 days of transitional care services. And there's a potential for even more reduction in hospital readmissions with that type of adaptation. Most importantly, there's potential for a range of services. So there's a big upfront investment in building the hospital without walls. Once you have all of those in-home components in place, once you have a 24/7 care team in place, there's a lot of services that you can offer. In addition to hospital level care at home, you could deliver post-acute rehab services at home, inpatient hospice at home, post-surgical care at home. And so you don't need separate buildings for all of those things. Once you have that mobile care team in place, you can add on a lot of other range of services in the home. There's also variation in how much of care is delivered via telemedicine versus in-person care, and variation in the composition of the interdisciplinary care team. So circling back to that last audience response question, here's a list of intervention characteristics that the CFIR model predicts will say how quickly or how slowly an intervention will spread. And hospital at home has a lot of features going for it. So advantages to spread include the strength and quality of the evidence, There is some evidence for a relative advantage over usual care, and we reviewed some of the evidence showing a promise in being able to move the needle on the quintuple aim. It is a fairly adaptable model. Cost is in the middle here. So there's a lot of cost upfront, a lot of investment and be able to build all those core components. But once it's up and running, there actually is a payment model now to support its continuation and sustainability. The biggest barriers to spread are the ones at the bottom here, trialability and complexity. And what trialability means is this is the ability of organizations to test it on a small scale. It's really difficult to build this as a small test of change because you need all of those components in place to just safely care for just one patient. Complexity is the perceived difficulty of the intervention. That can be how long it takes to set up the number of people involved, the scope, and also any disruptiveness to current practice. So now you're all experts on barriers and facilitators to dissemination. What about equity? So considering the wide variation in adaptable parts of the model, there's a lot of decisions that need to be made during the implementation process. And so I wanted to review how some of those design decisions might impact health disparities. So this brings us to our fourth and final audience response question. And the question is, to accommodate the needs of the aging population in the United States, the 1990 Americans with Disabilities Act requires buildings constructed after 1992 to be readily accessible to individuals with disabilities. This applies to public buildings and private homes. So go ahead and pick your answer. Is this true or false? We still have answers coming in. Okay, wow. Okay, pretty even mix here. So 46% of the audience said true. 54% of the audience said false. So the answer is actually false. So while the Americans with Disabilities Act does apply to public buildings, it doesn't apply to private homes. And what that means is that unlike a hospital building, the homes of many patients receiving hospital care may not be handicapped accessible, and maybe that's okay when they're feeling well, but it could be a barrier to care if someone has had a decline in their function while they're sick. So many private homes in the US are not handicapped accessible. It's estimated that 40% of Americans turning 65 each year will live in inaccessible homes. And so this is where I'd like to introduce the term housing-related disability. And if you haven't heard this term before, it means that someone's experiencing disability due to an environmental cause. So for example, in Baltimore, row houses are very common house design there, and it's very common to have bathrooms on the second floor. So someone living in that type of environment with mobility limitations, if their setups on the first floor might not be able to get to the bathroom independently, whereas if they were living in a single-story home or other type of setup, they could use the bathroom independently. It's estimated that 14% of community dwelling older adults experience some degree of housing-related disability. And unfortunately, older adults who experience this are more likely to be Black, female, and have lower household incomes. The good news is that housing-related disability is modifiable, and there's interventions out there to address it. One of the interventions is called Capable, and I won't go into detail about that model specifically in this presentation, other than to say that one of the core components of that model is to include a home repair person as part of the interdisciplinary team. And so while expanding the interdisciplinary team to include a home repair person hasn't specifically been studied as part of hospital at home, this is an adaptation to the model that our team here at UW has decided to include as part of our version of hospital at home through a partnership with a nonprofit called Project Home. So this will be able to address some components of housing-related disability and other environmental safety concerns for hospital at home patients. Access to a safe care environment is only one of many equity considerations that are important to take into account when implementing hospital at home. And there's a long list of other considerations which are outlined here. And there was actually a recent editorial published on this related to the many different versions of hospital at home that can exist out there. So other important equity considerations include access to technology. There's a lot of telemedicine and remote patient monitoring components. And so there's important decisions to be made to make those as inclusive as possible. Other potential equity considerations could be language barriers, socioeconomic status. We talked about how social support can be an important factor in being able to utilize this model. Racial and ethnic disparities, systemic racism and discrimination don't go away just because we're in the home setting. There can be variable access or benefit potentially due to health literacy, especially if patients are taking on a lot of self-administration tasks of medicines during their care episode. Caregiver burden is a consideration. We already talked about potential concerns about increased stress on caregivers. And then finally, there could be differential access, and we know there's differential access to the Medicare waiver specifically based on insurance status and also based on uptake and utilization of this care model in rural locations. So we spent some time at the beginning of the presentation talking about who's most likely to benefit. It's equally important to talk about who might not be served by the intervention. Are there people being systemically excluded or otherwise with differential access? And fortunately, we have a lot of information from those 3 landmark studies that were done in the US, not only about the participants, but about the non-participants, and a lot of information about factors associated with declining to participate. So this table is from the Brigham and Women's randomized controlled trial. They actually had a pretty high rate of eligible patients who declined enrollment. 63% of eligible patients did not choose to participate. And while that is a high number, the good news is that there were no significant differences in age, gender, race, or ethnicity among participants or non-participants. Interestingly, the main factor that was associated with declining to participate was being single. So those who were single were 2.5 times more likely to choose to be admitted to the hospital building compared to those who were partnered. And so this does point to potentially some differential access or at least acceptability of these services by social support status. This table is from the Mount Sinai Demonstration Project. They had a much lower rate of declining to participate. So in their study, only 33% of eligible patients declined enrollment in the hospital at home service. And they went into a lot of detail about reasons for declining. The most common reason was just a stated preference to receive care in the hospital building. But a lot of the other reasons do relate to some element of social support. And those are the ones that I highlighted in bold. So there may be privacy concerns, not wanting visitors in their home, some concerns about that the receiving hospital care at home might be inconvenient for them or their family, perceptions of insufficient social support, or maybe they do have caregivers who are already in need of respite. So for those who do have adequate social supports, there kind of still remains this question begged of does hospital at home add to their stress? And there's only been one study in the US that's looked at family member stress related to hospital at home. The survey of family members we talked about before was specifically about their satisfaction with their care, not specifically about family member stress. So this study surveyed family members who were not necessarily caregivers of patients, but family members patients identified when they were receiving hospital level care compared to patients receiving care in a hospital building. And the survey asked 15 questions about their level of stress. And you can imagine, you know, it's stressful to have any family members in the hospital, whether it's at home or in a hospital building. And hospital care at home was actually associated with lower odds of family member stress compared to the traditional hospital stay. So even though, there might be more care tasks, there may be some perceptions that they don't have the capacity to really participate in this model. The stress didn't play out that it was higher in hospital at home patients and was actually lower in this study. So, going through some of that list of potential barriers to access, the technology gap or digital divide is important to consider. There's a lot of telemedicine and remote patient monitoring that can really enhance the care and enhance the model. But there needs to be a thoughtful way to implement that in an inclusive way. And so there was recently a paper that came out in 2022 that went over best practices for technology-enabled hospital at home and equity considerations to making the care as inclusive as possible. Some of the best practices, including providing equipment so that patients don't need to have their own computers, they don't need to have their own internet, using adaptive equipment either through the technology itself or, for example, use of pocket talkers if there's hearing impairment or adaptations for vision impairment, and then having live assistants or staff facilitators help with the technology. Even if you implement all of these though, there's still an importance of having inpatient care available as an option. And this is a quote from one of the very high-tech programs that says, our experience has taught us that hospital at home patients with hearing impairment, cognitive impairment, or who have insufficient caregiver support are better served with a higher proportion of in-person visits. So that technology can be really helpful. It can enhance the care, and it's a tool though, and the care shouldn't be dependent on it. So there may seem like a choice out there to build the hospital at home programs as high tech or high touch, but really you need both. And then finally, we know there's differential access to this care currently across the US. Access to hospital at home in rural settings is almost non-existent. So less than 0.01% of hospitals in rural areas are participating in that Medicare waiver that I talked about. Factors associated with participation in the waiver are major teaching hospitals, large hospitals, and hospitals in metropolitan areas. And also the ability to include Medicaid members as part of that Medicare waiver varies by state. And Wisconsin is actually one of the states where Medicaid members, at least at this point in time, are not able to participate in that waiver. So the list of equity considerations when implementing hospital at home is extensive. And while we may not be able to solve all of these problems at once, we have made it a priority in our version of hospital at home here at UW to take action where we can to build the most inclusive version of hospital at home possible and move the needle on health equity goals. So this is just a list of some of the actions that we're taking towards that goal. First is screening all potential participants for social determinants of health. So this includes, people who choose to enroll, but also people who choose not to enroll. We don't want to just exclude people if they have inadequate social support. If there's a need identified, we want to be able to connect them with resources to address it. I talked about some of our adaptations to the interdisciplinary care team, including a full-time social worker and adding that home repair person to the interdisciplinary team. I mentioned that we'll be supplying everybody with a tablet that connects to the cell service, so patients don't need their own equipment or own internet. There's a focus on caregiver training and support among our team-based care model. We'll have access to the full range of interpreter services, including in-person interpreters when needed. Patients would have access to meal delivery if there's food insecurity or transportation otherwise for medical needs during that acute care episode. And then finally, there's faculty here who are taking a national leadership role in advocacy for inclusion of Medicaid members and access to a hospital at home in rural areas. So in summary, hospital at home can deliver safe and effective care to adults of a broad age range who have safe home environments. Compared to traditional hospitals, hospital at home can improve clinical outcomes, reduce readmissions, and reduce costs of care. The largest current barrier to dissemination is high complexity that limits ability to try it on a small scale. And then finally, while there's a lot of equity considerations when implementing hospital at home, many of those challenges can also be opportunities to address social determinants of health. So I would like to acknowledge all of my colleagues across divisions and departments who've been involved in planning for implementation of hospital at home, many of whom are in the audience, especially Dr. Josh Shapiro, who is our home-based hospital care medical director from the Division of Hospital Medicine, Brenda Larson, our program manager, and Mandy McGowan is our operational lead, who's in the audience and can help answer any questions.
So thank you, Melissa, for an amazing Grand Rounds as ever. And we have lots of time for questions, which is good. I'm going to start off with, why do you think that OB status patients are not really included in the current payment model? Do you see a future for that?
Yeah, so that's a good question, and I can give my perspective on that, but yeah, Mandy or Nicole might have other perspectives. But so there's actually internationally have been some concerns about gaming the system, especially where hospital at home is really widely implemented in Australia. Sometimes there have been concerns about patients who don't meet inpatient level criteria being labeled as inpatients, being reimbursed as inpatients, but they're actually outpatients. And so that's kind of Medicare with this waiver is being very strict about saying, you know, we want to know what your criteria is that these patients actually do need inpatient level care, and we're not paying you for inpatient level care when they're actually outpatients. So there is quite a gray area with that observation status sometimes. And I think, yeah, there's definitely a potential clinical benefit, but I think that probably there will need to be more regulatory clarity on how that is defined and reimbursed.
Great, questions in the audience. All right, here's Zakowski.
Hey, very awesome presentation, very interesting. One thing I'm wondering about, if there's any evidence about time patient spends in the emergency department, because we know that's kind of a barrier to getting patients in the hospital, but I would imagine that's even a bigger barrier to get from emergency department to home. Is there any data about that, or your thoughts?
Yeah, thank you. So that was something that was looked at as part of the Brigham and Women's study, just because, you know, we don't want there to be unintended consequences of having adding to capacity in the emergency department. The emergency department is already overwhelmed. There's a lot of boarding beds, and if there's a delay in getting patients home, then, you know, we don't want to adversely affect that. In the Brigham and Women's study, there was no significant differences in waiting time in the emergency room, but that's certainly a possibility. And it's something that we want to make sure we track and that we're doing well once it's launched here.
Great, and we have a question from the audience. What do you find are the biggest challenges in growing home-based care programs?
In growing home-based care programs in general, I think, you know, the payment model barriers are decreasing, but I think that is a consideration that is challenging, especially in the US, because so much is based on the volume of patients seen. And when you're caring for patients in the home, there's a lot of travel time. You can't really get that same type of efficiency that you would when patients are coming to you. So I think, you know, a lot of the transitions happening to value-based care are really going to be beneficial to invest in programs that impact the quintuple aim, even if the volume of patients served is not as high.
Out of curiosity, do you ever foresee the potential partnering with, say, community paramedics to almost do urgent care at home?
Yes, yeah, that's a really exciting piece of hospital at home work. And there are programs that do that already. So for example, Mount Sinai's program, they have a partnership with their community paramedics where if anything happens overnight, and this was true for their hospital at home program and their home-based primary care program, a paramedic can come on site, evaluate the patient, log into a video visit with the on-call physician. And that's a really exciting way to get patients' needs met. So yeah, I think that's a huge opportunity for improvement and something that we want to work towards in the future here. And Mandy's shaking her head. I'll see if she has anything to add to that or any of the
Yeah.
other questions.
Yes, that's something that we talked with Madison Fire about early in this project planning, and they are interested but did not have capacity to even think about it. A lot of desire, but no capacity. So we'll keep talking to them.
That's very cool. Cool. Oh, 2 more questions rolling in while we're talking. So question number 1, how will you stratify the social determinants to understand needs and any risks of stigmatizing?
Yeah, that's an important question. And I'm not sure who asked that, but would be happy to take any advice from that person as we're rolling out the program. But the social determinants of health screening that's going to be done for our patient population is some of the standard workflows that have been built into Epic and some of the standard workflows that are already happening in the emergency room. So we're not adding to that other than our own eligibility criteria. If someone is interested in hospital at home, we will ask them more detailed questions about their home environment and social support, but the base standard screening is already being done. And there's already workflows in place for that.
And then a comment and a question from the excellent Dr. Bartles. Wonderful presentation. Any additional ideas for people who live alone? This comes up post arthroplasty often, as well with shorter stays and outpatient procedures.
Yeah, that's a great question. And so for people who live alone or who don't have someone to stay with them after surgery or during this care episode, there is an opportunity for varying levels of CNA or home health aid assistance. The challenge with that, and we've talked to some other programs that have provided high levels of home health aides, is that it's once you put those in place, it's really difficult to end them. And because there's not great any coverage that our insurance systems currently offer outside of the VA or outside of dually eligible programs in the US for those long-term services and support. So if there was a better way to put those in place and make them more sustainable, that could be a really great option to make this more inclusive. I think in the short term, kind of like the acute rehab hospitals, we would really need to know that it's temporary to be able to put something in place. And post-op is a good example of that, in order to, kind of not leave people hanging and give them something and then take it away.
Yeah, I can imagine it wouldn't feel very good to identify a need and then not be able to address it.
Yeah, Mary had a question.
I'm really interested if you could speak a little bit more about how your team anticipates making a decision about the balance of in-person visits and using the telemedicine. As you know, I work in mental health. A lot of mental health is delivered over telemedicine right now. There's not a lot of good guidance about how to make a decision based on, clinical necessity, and there's lots of factors. And I'm thinking about how would you decide as a team, for that acute care level about when you need to put the resources into a home visit, and curious how you guys are going to handle that.
Yeah, that's a really great question. I think that's one of the biggest areas where we want to be a group that can learn from our experiences over time. And so that's something that we want to be very intentional about. We're actually, with the program launch, while we have the full telemedicine capabilities there to use, we will be 100% in person and then back off from there. So the goal is to start 100% in person, have the technology there available to supplement the care. And then as we learn over time what we're more comfortable with addressing over telemedicine, gradually build it in and try to optimize it. And if there's anyone interested in working on projects like that, we would welcome your collaboration.
Excellent. And I think that's it for online. And look at that, 8:58, perfect timing. So thank you all for coming. Make sure you grab a donut or something on the way out to get your sugar rush for the day. Have a wonderful week and we'll see you next time.
Did a great job.